Good afternoon and welcome to today's webinar, Help for Clinicians Caring for Patients with Diabetes. We are thrilled to have you with us today. We thank the Maryland Department of Health for providing this wonderful resource. And we want to thank also Maryland Primary Care Program for helping to promote the webinar today. I am going to just let you know we have an incredible group of speakers. They are Dr. Peters, Dr. Fiddler, Mrs. Coddington, Ms. Burch, Ms. Kelly, Ms. Eagle, and Ms. Vaith. More about them later in the presentation. I want to remind you that you are able to submit questions via the question tab throughout the presentation. We will have time for questions and answers at the end, and you'll be able to open your mic if you have additional comments or questions. I also want to remind you there will be a post survey at the end, especially if you are interested in CMEs. Please complete that. So first, I want to move by introducing our first speaker. Dr. Sadie Peters is the Medical Director in the Center for Population Health Initiatives at the Maryland Department of Health. She was an internist who spent 8 years in clinical work at Johns Hopkins Community Physicians before joining the public health sector. She's very interested in innovative interventions that expand population-level preventive health and management of chronic diseases like diabetes. Dr. Peters, I want to turn it over to you. Unmute your mic, please.
Here we go. Can you hear me now?
Yes.
All right. So let's go back. Great. Thank you. Thank you, everyone, for the opportunity to talk with you today. I'm going to turn this up just a little bit. This webinar series is really designed to reinforce the idea that for clinical practitioners and provider teams, there are a lot of assets in the community or at the health systems level that can be beneficial to you and your patients, and which many of you may not be taking full advantage of. Many of the presenters in this series, and today as well, will talk to you through how to access these resources, and we hope by the end of today's session, you'll feel a renewed commitment to seeking out and using many of these diabetes care resources that may actually lie outside your workplace exam rooms and clinic walls. There are more than 100 million adults in the United States living with diabetes or prediabetes, and nationally, about 1 in every 7 healthcare dollars is spent treating diabetes and its complications. Among the 6.1 million people living in Maryland, there are an estimated 2.1 million adults with diabetes or prediabetes. 1.6 million of those are people with prediabetes, 90% of whom don't know they have it. Diabetes is the 6th leading cause of death in our state, and diabetes and prediabetes are pretty costly for both individuals and for the healthcare sector in general. There's an estimated $2 billion in lost productivity annually and annual medical costs of $4.9 billion. People with diabetes have more than twice the medical expenses of people who do not have diabetes, so this is truly burdensome to the individual as well. When we look at diabetes prevalence in the state, it's clear that there is great variation. Maryland's overall prevalence, and that's in the yellow triangle in the middle, is just over 10%, but some counties have a prevalence of 15%, which you can see to the left, and others have a lower than average prevalence of 7 or 8%, which is seen over on the right. As with the rest of the nation, diabetes in Maryland is not equally distributed by race and ethnicity. Data from the Behavioral Risk Factor Surveillance System, the BRFSS, shows higher prevalence among Blacks and other minority groups compared to whites. In some geographic areas of the state, as you can see on the right, the difference in the distribution of diabetes by race is quite stark. And in other counties in our state, we simply don't have enough reliable data to clearly understand the diabetes disparity by race and ethnicity. The COVID pandemic, which has changed so many aspects of our lives, has further aimed the spotlight on health inequities across our nation and indeed in our own state. Emerging evidence points to the increased risk for hospitalization, ICU admission, and death for people with diabetes who have SARS-CoV infection compared to those who do not have diabetes. A study published this past May found that 1 in 10 hospitalized COVID-19 patients with diabetes die within 7 days of admission, and 1 in 5 need a ventilator within 7 days. Clearly, diabetes care is still extremely important during this pandemic. So one of the key messages today is that clinical providers are not alone in addressing diabetes and its risks. Employers are concerned about how diabetes affects productivity. Health insurance payers disclose, perhaps complain, that a large percent of their claims payouts are for diabetes-related illnesses. And as the burden of type 2 diabetes shifts to include younger people, even schools are struggling with how to properly support an increasing number of students with diabetes. Acknowledging that diabetes impacts everyone and that broad, multi-level interventions plus alignment of existing resources is needed to improve diabetes outcomes at the population level, last year the Maryland Department of Health, in collaboration with many partners, introduced the Maryland Diabetes Action Plan. The plan relies on everyone's involvement and has strategies and action steps for healthcare providers and health systems, but also for community groups, for employers and insurers, and for state and local government. Just as it calls for a multi-sector approach, the Diabetes Action Plan also intends to address this chronic condition across the diabetes risk continuum. We know that excess weight is associated with an individual's progression to diabetes, but it's important to remember that interventions can take place even more upstream to keep people at a healthy weight so that they stay at the far left of the continuum. The Diabetes Action Plan is laid out such that there are suggestions for action in each of these categories. An example of what clinical providers can do to keep people in the healthy weight category is increased routine and frequent preconception weight counseling for patients who desire or are planning a pregnancy, since we know excess weight during pregnancy is associated with gestational diabetes, yet another risk for diabetes later in life. Another example of upstream action for healthcare provider teams and health systems is to identify food insecurity and address it, not just as a short-term fix, but as a possible pervasive long-term problem that can heavily impact not just the diabetes, but all the other chronic health conditions the person or family may be facing. So we've just seen the plan's framework encompasses all the populations across the continuum and calls for both upstream and downstream actions. There are plenty of action steps in the sections for managing diabetes and its complications. These are ones that healthcare providers are already familiar with, like you should refer people with diabetes for vision screening, conduct regular screening for kidney disease, and ensure podiatry involvement for foot care. In this category of managing diabetes and its complications, however, there are also suggestions to ensure that all people with diabetes have an emergency preparedness plan. This is especially important in this era of severe weather changes and wide-scale disruption of daily life, like that which happens with an unexpected novel coronavirus pandemic. So this is yet another depiction of the continuum, but with a slightly different way of looking at the types of interventions planned across the many partner types. State and local government, and even employers and insurers, can have huge impact in bucket 3, which is over to the left, where they can implement or strengthen policies that make it easier for people to access healthy food and incentivize regular, safe physical activity. actions in bucket 2 include expanding availability and enrollment in community-based programs like the National Diabetes Prevention Program, which should decrease the number of people who progress to diagnose diabetes on the far right. Bucket 1's interventions for health systems undergird the need to improve overall care quality for people with diabetes, and the plan has lots of action steps for that part of the continuum as well. And those would include things like expanding electronic referrals through CRISP, our health information exchange, and maximizing the 6 core elements of the chronic care model to fully use all the healthcare team so that we can optimize care for every patient. So, as the next speakers share their expertise, I hope you come away with some nuggets you're able to use as you continue your work with people with diabetes or at risk for diabetes. As we all work together toward a more comprehensive and systematic approach to diabetes prevention and care across the state, I also want to encourage you to take a look at the Diabetes Action Plan. It's available online, and you can simply Google Maryland Diabetes Action Plan to find it, but the link is included in these slides. There's a lot going on to address diabetes in Maryland, and you are not alone. Sue, back to you.
Thank you, Dr. Peters. Wonderful information. I know it will be helpful to everyone who's attending. And now I would like to introduce an incredible team. With us today is Dr. Catherine Fiddler, who is the current Vice President of Population Health for Telehealth. She has the responsibility for hospital and community care management and coordination teams and community initiatives. And with her is Ms. Susan Cottingim. She's a registered licensed dietitian nutritionist and a certified diabetes care and education specialist and coordinator for nutrition and diabetes education at Telehealth. Also with them is Kelly Burch. Ms. Burch has had type 1 diabetes for 35 years. She's a certified diabetes educator and works with newly diagnosed patients, people with A1Cs over 9, and patients with knowledge deficits. I'm going to turn it over to you now.
Thank you, Sue. Kelly, can you move forward one slide? And one more. Great. Thank you, everyone. So I am Catherine Fiddler. We are Tidal Health. So this is new for us. We've been Tidal Health since 1 September. Previously, we were 2 separate hospitals, Nanticoke and Peninsula, and now have come together with a physician medical group. So we now have nearly 5,000 team members in the 7 counties on the lower shore. We are the largest health system on the shore. We have a new Tidal Health Medical Partners, a 250 provider enterprise with nearly 700 team members. And we're very, very excited with the scale and the scope of what we're able to accomplish, especially as we discuss diabetes.
Oops.
That's right.
Sorry.
You're fine.
Oh, it went again. That's not funny.
All right.
Let me go back. Oh.
You're fine. You can stay right there. Okay. So I'd like to introduce our fabulous Peninsula Regional, Tidal Health Peninsula Regional Diabetes Education team. We do have teams in Delaware and in Maryland supporting our diabetes initiatives across the continuum. So if you two could take it away and talk about our team.
Well, certainly I would love to tell. This is Kelly Burch. I would love to talk about our inpatient diabetes education, as that is where I live many days. Before, we were really focusing on COVID and, you know, the changes that we had to make, and we had to make them fairly quickly. Prior to COVID, we received referrals for our newly diagnosed patients, patients with A1Cs over 9, patients with type 1. They may have had an insulin pump or just really needed education. So what we did was we would go to the room and, of course, assess the patient and, you know, ask them if they had the tools they needed to manage their diabetes at home, such as, you know, do they have a meter? You know, did they know, did they know what did they know about diabetes and what could we teach them? So we really did what we call diabetes survival skills in person with the patient. So then COVID popped up and we had to make some changes because at the beginning there were no in-person visits. So we had to rely on our telephone, which was something that was a little different for us. Our nursing team was also fantastic at helping out wherever they could. So, we would, number one, depending on what was going on, we would call the patient's nurse, have them give the diabetes survival skill booklet, for review with the patient. We would also get them a meter. We did that a little differently as well. If they were on a COVID unit, they had runners and they would come to us and get a meter. So we would get those back to our patients, and they were able to do lots of great insulin instruction, and they also did meter teaching, which is a little out of their scope right now, but that they did an amazing job. And sometimes the patient even, we even have pharmacy as part of our team because the patient would get the meter and or pick the meter up at pharmacy on their way out, and they would be able to show them as well. So it was really a team effort. We then, after we got nursing involved, we would call the patient in the room and we reviewed the booklet. We found out what they knew and what they didn't know, and then we would review those survival skills. Blood glucose target goals, 80 to 130, all of the ranges, and when to check, and what to look for, how to treat a low, how to treat a high. So there were times though that the patient was just too sick for this. They could have been admitted, with a COVID diagnosis, and you could tell they were short of breath. But a lot of patients, even if they weren't COVID, they would just, let us call their family because they maybe didn't want to talk on the phone. The families were amazingly receptive. And it just seemed like we were able to get more information from the families than we did the patients. Imagine that. Sorry, trying to change it. So the family really did let us know, those important challenges. But what I wanted to talk about is what we learned also during COVID. We learned, number one, how to attach our contact information to the after visit summary. Well, it was probably there, but as we've been going, doing inpatient teaching, we've kind of done things, we go in, we give them the booklet, we tell them about our diabetes self-management and education support classes, and we tell them about medical nutrition therapy, and we give them the booklet, that does have that information in it, but that's primarily what we do, The nice thing also that we could attach to the after visit summary were things like specific insulin instructions, so that if the patient did get home and something was missed, it was available. And when we put our contact information on the after visit summary, we included our phone number. Many times I put my email so that a patient could have easy access to a diabetes educator. We also we found out another thing while we were doing this, that we could actually route our notes to the primary care or endocrinology. So that was kind of a nice thing. And at that point, we saw the knowledge deficit. We would send that note to, like I said, the PCP or endo for the DSMES classes, or medical nutrition therapy, or even CGM training. If the patient had gotten, sometimes we got a report from the inpatient, oh, I received my sensor or my CGM, my continuous glucose monitor, and I don't know how to use it. So we were able to route our notes, get the referrals back for those, and that was a really nice thing as well. And we've seen a lot more referrals coming into our program. But back to the family, it was really something because patients don't always tell you what you want to hear. So the challenges that the patients were giving us, maybe the patient couldn't afford their medications. So at that point, it wasn't great. We don't want to have patients that can't afford their meds, but during COVID, we found these amazing assistance programs for insulin, for other medications, and even some of the continuous glucose monitors. So all of that was there to really share with the patients or with the patient's family. So that was a big help. Sometimes, patients are forgetful, but when they talk to you, they remember all the time, that I'm always taking my medication. I am, they make you feel as though they're pretty organized and they've got it together. Now, their A1C or their numbers might not tell us that, so we know something's off, But again, family was really, really great. They also would tell us, because they do like to be a little snitches on their family, no harm intended. I've had diabetes for a long time and I love my family. But they would tell us, the patients aren't monitoring and, maybe they have barriers to even healthy eating, food insecurities, knowledge deficits, and again, people don't always want to change their lifestyle. So, the nice thing about it is you tell this to a diabetes educator and all of a sudden, we're thinking, okay, food insecurity. So we need to get them to our transition team or, some of our other team that helps, with things like that. Knowledge deficit, we're right there. We definitely want to teach patients. We want to talk to them about maybe not monitoring. What can we do? We want to talk to them also about their medications. Do we need to put Post-its up? We want to help these patients to live a healthy life with diabetes. Not wanting to change habits. That's where you really, you have to talk and do some motivational interviewing. So we are there, it was just a great thing to see and hear because we didn't know. So what you do know, you can work on to fix as a team. So the nice thing is we will continue using these new tools and we will be providing better and better services to our patients with diabetes. So that's really what we got out of that. And it was just an amazing, amazing journey. COVID, nobody wanted this, but it hit us and we really had to think outside the box. And I believe as a team, we worked and we did what we needed to do for our patients with diabetes. So Catherine, I think this is back to you.
Yeah, so unmute or mute yourself, Kelly. So as we all talk about COVID, I think one of the things the diabetes team, I can remember a day when I went over and said, there's going to be a day in the next week or so we're not going to be able to have any people come here. So how are we going to do this? And we started talking through telehealth. The initial response is, well, we can't do a group visit that way. I'm not sure how we're going to get patients in. Patients won't be receptive, all of the typical things for Tidal Health. But we realized if we wanted to continue to be able to care for this population, we were going to have to change. And our diabetes team was one of the first teams that actually embraced our WebEx technology and began to assign patient their visit time via WebEx. I can't say enough about their flexibility and their resilience in doing this and helping educate patients. Our diabetes team became WebEx experts on their own. They played with each other and shared screens and things to get very comfortable with it, and they became the IT resources for the patients that they were taking care of. We were able to support diabetes education classes fully online by April 1st, and we have completed successfully the classes, and they're going to talk a little bit about them, but the patients were very much engaged, and this team did a phenomenal job getting them up and running. So with that, I think, Susan, you take it away.
I think
Kelly's got one more. Yeah.
One more for me, sorry. Real quickly, I will tell you one of the things that I honestly in my brain was not sure we were going to be able to do. We were doing continuous glucose monitoring training with patients, and really it was like a hands-on. When they would come into the office, we really had to show them and really show them, online, what they needed to do. But what we learned during COVID again is with video and audio, we had it was amazing. We were able to do CGM training. Some of these patients were over 70. My first one, I want to say he was 72 or 73. Now he needed a little help with his daughter, to help him kind of get on and get rolling with it. But it was just amazing. Some of those patients without video, we had to do over the phone. And I kid you not, I think sometimes I just closed my eyes and imagined what they had in their hand. So that was what was really, really, it was difficult, but it was definitely worth it because we got about 60% of our patients, done through telehealth. Now there were the few, maybe 40%, they waited and they just wanted to wait until we got back to some in-person training. But again, it was very much a success. And I just really, I'm not sure how we did it, but when you have to do it, you do it. And I believe we did it very well. So the next slide will be Susan. Oh.
So for our diabetes health management education and support, as Catherine mentioned, we had to switch everybody over. So many of these patients we had scheduled already, and we had to call and tell them, well, we're going to be switching to telehealth. And we really had a pretty full class or classes, because we do a day in the evening. So our initial classes were not maxed out, but they were fuller. It was a good 4 to 5 people, and that was nice to try to do the telehealth with. So prior to the classes, we did do most everything in person. We had a pre-assessment where each person completed, they would come in, we would do an assessment prior to the start of classes. And then each person, and if they had a support person that wanted to attend, they could. So they would come for the 2-hour class, and we did 4 classes, 2 hours each. And then after that, we completed an evaluation. So that was our pre-COVID. And then, so during COVID, we did the pre-assessment by phone, or we tried to do them by telehealth, because that way the patient could practice. We had an excellent support with our administrative assistant, Bonnie, who helped everybody find a way to practice or connect. So she had to send out emails with the link for the meeting. But our IS department was excellent too, in that they were a big support. They helped us learn all this and came over for reinforced training. And they sent us a link that we could send to patients so that they could do a test. And that's really good if people will do it. So, finding that people sometimes would say, oh yeah, I was going to do that tomorrow, but calling to remind them to get on to check ahead of time so that they could join the telehealth as soon as it would be started. Whenever we had the classes, they would join by email, through their email, and join the meeting. And then on screen, they would use the audio. So during the classes, everybody that participated did the video and audio. And they were very happy to participate. A lot of times we didn't have to call on them. They were very participatory, and they really enjoyed not having to leave their house. And that first class that we did in the evening, a lot of people really enjoyed that aspect of it, that they didn't have to come home from work and, get in the car and turn around and go anywhere. And the smaller classes, we found that we had a little bit more of a challenge in getting people to participate. However, the class itself, we did PowerPoints for our materials, and then we also mailed them information. So they actually had all the handouts that they could view, and then we had additional activities, during the class that we would involve them in. So most of the time, everybody participated, and they seemed to like the feedback, that it was not having to get in the car, drive, come back. And with the WebEx feature, we were able to share content. So WebEx allows you to do the group class, so we could have a good group, and then we also had the opportunity to share content, which made it easier, for things that we wanted to review. So it wasn't just seeing the people, it was also going through the materials in the class. And then we would mail those out to everybody, so they had them in advance or during the course of the class as well. So based on what we wanted them to view, and also information we needed to get back from them. All right, so the challenges that we faced in doing the diabetes self-management education support online, initially was everybody getting them online at the start time, because sometimes people had practice, some people didn't. So the first 15, 20 minutes, was a challenge trying to make sure everybody was at the same place. Also, there were some issues with background noise, but that's just, again, training people that are starting with telehealth to use their mute, and make sure that if they know somebody's going to come in the room or something ends up happening at home, that they mute so that it doesn't disrupt the class. We did have a few people that disappeared halfway through or near the end, and so we were each in our office on the WebEx, so we couldn't always talk to each other. And at the end, we were like, "Hey, did so-and-so, looks like he disappeared." So we would have to then follow up with them and try to get them back in to make up the class, but just getting in touch with them to make sure that we knew where they were and we could get them back in the session again. Some people that were on the cell phones, that was a challenge, because the the camera would go where they were. So sometimes it was helpful. We saw the refrigerators, but other times we may have seen, house parts or body parts that we didn't always want to. But that was always an interesting aspect of it. And then the challenge that we had was the evaluation form, because normally we did that in person when people finished the class. So we had to figure out a way to, get it completed. We tried to mail it out, and we're having some success with that. But our next step is to really do something, develop an online survey so that people can do that via email, because it's just a challenge. If they didn't take the telehealth, and they're taking a telehealth class, so to get information back from them on paper is a challenge. So the benefits of the telehealth were, it was a more relaxed environment for most people. They seemed to participate more. And there also didn't seem to be a lot of people, one person taking over the class. We find that in our group sometimes you have one or two chatty people that seem to overwhelm everybody. And it didn't seem to be quite as much of a problem with the telehealth classes. Again, I mentioned they didn't have to travel, and we could chat with people, so sometimes we'd have a few people get on a little early. We could chat with them and, get to know a little bit more about them, make it more personal. And then our satisfaction for the classes still is about the same. So we don't have a lot of results because, again, we haven't done as many as we have with our in-person classes. But just with the short period of time we've done this year, our satisfaction is 93%. And again, that's not getting everybody's results back, but probably at least half of the people that have taken the classes. And then we would compare that with our satisfaction rate earlier in the year, which was about 94%. So it's still on target. People do like it, and hopefully that will just improve with time. So with our diabetes self-management, education, and support, things we learned, many people still were not prepared and required some coaching. And so that's a challenge. One of the things we've also done is our medical nutrition therapy services were moved to telehealth too. And we found that to be a big issue, that people, that you tune in for the appointment, they're not there, you got to call, and then they're either trying to get hooked up or they tried and had trouble. So, it's coaching them. And for us, learning how, an iPhone might work different from Android, and where they have to go in their settings. And so we're learning with that technology too. And as I mentioned, our IS team has been very helpful. Another thing that is really important is we had a telehealth team that met every 2 to 3 times a week. And it included all the providers, or not all the providers, but representatives from all the different departments, the providers, as well as our telehealth experts, and then finance. And so finance was critical in this too, because we do bill for our services. And so finance, knowing what the guidelines were that came out on telehealth, and making sure everything was done properly in terms of making sure we had telehealth consents and that we were coding and billing everything properly. So I can't say enough about how helpful the IS team was, the finance, Catherine, and everybody just encouraging us to, work through it all. And the training is very important. So we had to train and then train again, and we're still learning things because WebEx updates things and you realize it changes. So you have to figure out, what you're doing. And practice does make a difference. So as Catherine mentioned, we did do a lot of practice. We set up test WebExes, and we all would get on there and practice sharing content. And, it's just a little tricky. And I wouldn't say we're still experts, we're getting there, but, we have times that it doesn't work, but it's been very good. So we did use those practice sessions. Don't take no for an answer. And Catherine would let us take no for an answer. So she was good about, you're going to do this, I know you can do it. And so that support was really helpful. And using the care coordination resources available is a good resource. So we have a good team here at Title Health Peninsula Regional. And then being resilient, so just going with the flow, trying to master what you can. And again, having that support was crucial. So we did work really well together as a team, and we still continue to do that. So it's been an interesting experience. Not one we would necessarily have chosen, but certainly has turned out well. And we're continuing to use telehealth, even though now we're bringing some patients back in and doing individual visits or group. We have started to do a group class in person as well. So now we're doing both services. Thank you for your time, and we appreciate you allowing us to share our experience with our telehealth during the COVID-19 pandemic. Thank you.
Terrific presentation and very inspiring. Thank you so much, Team Tidal Health. And now we're going to turn it over to Sadie Kelly. She is a patient liaison referral navigator at Doctors Community Practices. She's experienced in training and has absolutely done wonderful work in terms of staff development, workflow efficiency. She is skilled at providing patient outreach and communications, and my favorite is she does this with the ability to diffuse complaints and calm concerns. Tacita, take it away.
Thank you so much, Sue. Hello, everyone. Again, my name is Sadie Kelly, and I am a patient referral navigator with Doctors Community Practices with the Maryland Primary Care Program. Today, I'll just give you guys a brief summary on how my role help patients cope with the emotional aspects of dealing with diabetes. Patients with diabetes or any other chronic illness, they oftentimes struggle with disease management. You have a lot of patients feeling angry, guilty, or even frightened about the disease, and this can lead to patients feeling unmotivated to complete their diabetes self-care tasks. This can also become a serious or negative impact on patients if left unaddressed. Addressing patients' psychosocial factors in a treatment plan could break the barriers of diabetes self-care management. Addressing and supporting our patients through a lifespan from the beginning of the diagnosis with proper evaluation, from the beginning of diagnosis throughout the whole lifespan of the disease. With proper evaluation can be a major impact with helping our patients cope with this chronic illness. At Doctors Community Practices, we use 2 evaluations or questionnaires to evaluate our patients' well-being, along with our quality metrics. The first one you see here is something that you're probably very familiar with, and this is the Health and Well-Being Questionnaire. And that questionnaire helps us to determine how a patient feels or how they function on a personal social level, or just simply how they evaluate their lives as a whole. The second questionnaire is geared towards patients with diabetes that have already started a treatment plan. And this helps us measure how satisfied a patient is with their current treatment plan. And once we get these evaluations back, especially the diabetes questionnaire, it helps us let us know, how they're dealing with it emotionally and how we can support them emotionally. And we just heard all of this wonderful information from Tidal Health, and the diabetes education at Doctors Hospital is one that we refer a lot of our patients to. And just like Tidal Health, they are just a wonderful support system for our patients that are newly diagnosed, or even patients that have figured that they're not doing things too well as far as food therapy, or dealing with their glucose meter, or just needing someone to speak to or talk to. So our diabetes education, they do a lot for us. They help our patients with nutritional therapies, with exercise. They can help our patients with the insulin pumps training and the continuous glucose monitoring. So they really support us a lot with our patients. And I know during the COVID, a lot of the information and feedback that I've received is that families are being a little bit more involved now, because you've seen a lot of families that are starting to stay together a little bit more since the COVID has happened. So the family support has been a good feedback that we've been receiving from the diabetes group. So that made us feel very comfortable, because at first you would see a lot of patients that just was dealing with this disease on their own, and they didn't have a lot of support system. So hearing from the diabetes group that a lot of families are getting involved, it just made me feel, very comfortable, especially during these unforeseen circumstances with COVID. And another way that we try to deal with or help patients cope with the emotional aspects of diabetes is we introduce new ways of managing their diabetes. This first one you'll see is the continuous glucose monitoring that I've been hearing a lot throughout this presentation. It's just been very helpful to a lot of our patients. It avoids finger sticks. We're able to monitor it on our end. It's the provider side. It's a good it has a Medicare reimbursement and commercial reimbursement for our providers. You don't have to worry about the strips and the needles that go along with the lancets, along with the machine. It's just been a really, really popular device for our patients, especially with trying to introduce new things to them. And of course, we all may be familiar with the insulin pump. It's a really popular way of introducing something new to our patients to help them deal with managing their diabetes a little bit better. But I just wanted to say that following up with your patients is always a good idea. Closing that loop, track your referrals from the beginning through completion, track your no-shows, your cancellations, appointments referrals that's never been completed or never scheduled, calling the patients and reaching out to them for reminders or even coordinate that referral. Okay, lastly, it's okay. I'm just going to leave with the story that really let us know that we're on a good track with helping some of our patients coping with diabetes management. We had a middle-aged gentleman who came in, and he was a patient of ours for a while, and he was newly diagnosed with diabetes, and he just was frightened. He was so upset. He was confused. He didn't want to tell his family what was going on with him. He was having financial difficulties, and we were able to just sit down with him and help him with his social determinants. And that led to us giving him more resources on how he can better manage his diabetes. Like we were able to help him qualify for, not able to help him, but apply for the Qualified Medicare Beneficiary Program. We were able to coordinate the diabetes education for him. And he was just so happy that we were able to get things in a better state for him, that he referred a family friend of his to our clinic, and we're now also managing his diabetes as well. So I just want to say, just being supportive, emotional to the patients is also a big deal. I know sometimes as direct patient care, we may not have the time to do that, but that's one of the good things that the Maryland primary care programs, they have designed this role for us to help patients to deal with social determinants and emotional aspects of their disease management. And that'll be it for me, and I thank you guys for having me.
Sadie, thank you so much. That's really inspiring, wonderful story. And at this point, I'm going to turn it over to Leanne Eagle, who is the Executive Director of the Maryland Living Well Center for Excellence. She is the Health and Wellness Director, as well as I said, the Executive Director, and oversees training across the state of Maryland for a lot of the evidence-based programs. Turning it over to you, Leanne.
Thank you. So if we're going to move on to the next slide. Let's see. Okay, and here is the Maryland Living Well Center of Excellence. We are statewide. We are housed on the eastern shore of Maryland. We've been in existence since 2015. And these are all of the evidence-based practices that we do across the state. So this is all about linking older adults and people with disabilities to needed services under my COVID-19. Us, like most and other organizations, we had 100 classes that were happening across the state of Maryland. So within a 7-day period, we went down to 100 to 0. So we really had to think about how we were going to do things differently. So we started looking at the individuals that had gone through these my classes in the past, the diabetes self-management, chronic disease self-management, falls. And then one thing that we did find out was the people that had gone through these programs prior to COVID-19 were managing so much better because they had been taught how to self-manage. So that's an integral piece here. We made phone calls. We made over 700 calls. And what we came out of that was most people were interested in the home meals, the shelf-stable meals, the Meals on Wheels. The next request was transportation, which we know is always an issue. The next is they couldn't connect to their telehealth and access and training. So we actually spent a lot of time teaching people how to make that happen for them. The next, of course, which is no surprise, is PEARLS. PEARLS is an evidence-based program that is for depression. And we know at the time where these people were in their homes, they haven't seen their loved ones, they haven't seen their families. We started doing screenings and we started enrolling more people in PEARLS than ever before. And I really want to do a shout out to Fiddler and to, they just did an excellent job networking us and getting these people help on the outside. We started doing diabetes and chronic disease self-management virtually. So we're going to talk about the use of the my tablets up here in a minute. We actually started doing them one-on-one, and as part of we're able to make that happen now. So that was a very integral step. Maryland primary care. So that is helping us to facilitate, increase the PCP utilization and CRISP referrals. We've had 262 since last November. We are now screening for the my social determinants of health and the social isolation, which we know during like COVID-19 was higher than ever before. Down on the Eastern Shore, we actually screened 124 people, and these were the people that were coming into our gym on a daily basis. We screened them 1 month post, and 98% of them were in the red and the green. We actually, with a partnership with Matthew Smith and with Sue, we actually were able to create an upscale screener called Users. And that was really integral part that really brought light to us that said, like when we did the screener, it said, well, we didn't know why we felt this way. And thank you for letting us know. And that was very, like, that was an aha moment to us. We provided PEARLS and depression and social isolation. We also did the provided the diabetes self-management and the chronic disease self-management to 108 people by my virtual or in my person. Key strategies to ensure at-risk individuals to receive needed services. We got a direct API with Chris, so we're able to receive a referral. We're able to put in a alert. We're able to receive direct doctor referrals for these classes and do the screenings. We're able to do pre and post test tracking of hospitals and ER and what the costs are. So we can start to look at what is the actual cost savings. During this my COVID-19 standing meetings with the hospital care coordination team to assess the needs of services. This was phenomenal. On the Eastern Shore with Untitled Health, we stood up a 24-hour my command center statewide. If we had a case that came out on the Eastern Shore, we were able to call the Untitled Health case manager, and I would bet you 98% of the time they were already on top of that case, and we were just able to alert them that we were getting calls, and we were able not to make a duplicate service. So that was really, I would say, that partnership and closing that loop, because we have to make this a village. We all have to get out of our silos, because the community-based work, the clinical work has to marry each other if we're ever going to move that needle, because we can't all do it by ourselves. It takes the whole team. And this was some CRIS data that came out, and we were very excited to see this, because these are the people that actually went through the chronic disease management program. And it looked at the 12 months pre, 12 months post. And as you can see, this is when we didn't have that direct API. So that would mean we sometimes didn't get direct names to match. So now we should be able to get a lot more direct matches. But as you see this, we matched about my 52 with pre-data and my 55 with pre and post data. And we showed an actual cost savings is phenomenal, like 227,000 pre and 435 post. As you look down to the falls, we had a smaller match there, and we had a savings of about 64,000. So, I mean, it really speaks for itself. Pearls. And I mean, as we know, during this data is from November of 19 to 9/8/2020. So you can see we put across 185 cases across the state. And as you can see, we got a total remission of depressive symptoms is about a little over half. And the ones that achieved a response with an improved PHQ-9 is about my 70%. And here is what we came out of this. As we are working through our ACL, my chronic disease self-management and falls, we knew we needed a strong IT team. So prior to that happening, we've developed a partnership with Eagle Force. I'm in no relationship to, I'm in no relation to Eagle Force. That's basically when Eagle Force meant Eagle. And you're gonna hear Stanley Campbell is the CEO of Eagle Force. I'm gonna give him a few minutes here to talk about the device. And this is how we are going to start to network and allow our patients to be connected, as well as to engage them in classes. Thank you, Stanley, if you want to take the next 3 to 4 minutes, because you're going to hear him speak again on September 22nd.
Thank you, Leanne, and thanks for all of you all for your time and attention. So Leanne talked about a little bit about APIs. That's just the way that computers talk to each other. We come to Maryland as both familiar with Maryland. We have approximately 98% of the Medicare and Medicaid patients, about 99% of the CHIP patients. And then we message into with every insurance payer with the exception of Kaiser. So we are very familiar with the Maryland population. Tablets and the equipment that is available through some federal programs, they call them the Obama phones or the FCC phones. They come locked down with limited amount of time and limited amount of access. One of the things that working with Leanne and the folks with AARP and the University of Texas or Texas A&M, we found out even before COVID that those patients who are socially isolated become depressed, and as well, if you're managing things, chronic disease management like diabetes, hypertension, congestive heart failure, COPD, all of them carry with them those social determinants that were talked about a little bit earlier. So we decided that we would work with some of the insurance companies, with some of the phone companies that we have relationships with. And though you see T-Mobile here, it's basically anybody that's selling an Apple or a Samsung phone with the primary focus on the tablets for Samsung. And what we did was we negotiated 2 years for unlimited talk, unlimited text, and unlimited data. Thus, so we take grandma from having no phone or no access, from which I saw earlier in some of the Tidal Health where you're doing a telehealth visit, and we move them to having the best phone with no billing, meaning because we have COVID that has us all socially isolated to a certain extent, the clinical necessity for being able to write a prescription with no out-of-pocket to the patient, to receive a phone and to receive that phone or the tablet for 24 months already prepaid, that becomes a game changer. So then we went over to Zoom and we then showed them what we were doing and asked them if we could scale this to the national level. And even though we were able to show that we're working with Leanne with every 211 call coming into Maryland, and any referral from over 911 to 211 in Maryland, we're actually able to now give a telehealth ready video capability through Zoom at no cost to the provider, no cost to the patient. And because we're providing the devices, we can actually load up diabetes self-management. We can load up hypertension management, congestive heart failure, COPD, falls, or any other library programs that are now made eligible for virtual. And that includes a full scope elements associated with the Pearls program. So all the paper is basically removed from these problem areas. The agencies, as it relates to the technology, this is a HIPAA compliant system where we didn't take any of the emergency criteria or the 1135 waiver. We actually built this so that it could actually be sustainable beyond COVID, because after COVID, we will still have about 11 million Americans who are socially isolated, who receive things like Meals on Wheels and the like. And then lastly, the collection of these programs is built on a platform that is secure and interoperable and does have the ability for billing. So every single element, as these chronic disease management programs move from grants or from grant programs, be they personal grants or institutional grants, or even HRSA or CMS grants, these are now all with the confines of billability, and that becomes a game changer for chronic disease management. These devices are fully able to support them, and Leanne and her team are serving as a national exemplar. We happen to be sitting in Chicago to give a similar briefing on this week. And you guys in Maryland should be very proud of yourselves, particularly Leanne and her team and the Title Health folks. Thank you.
Okay.
Thank you. Thank you very much, both Leanne and Stanley. I think excellent information. So for providers to refer patients to MAC, the DSMES on CRISP, is there any upfront training that's required? So again, in terms of referring individuals, Leanne, I don't know if you want to take that or if you'd like for me to. Either one's fine.
Sue, you can take it just fine.
Okay. So the patients don't need training beforehand. Absolutely not. That's the purpose really of the evidence-based programs. And so we work with individuals who have diabetes or pre-diabetes, and certainly their family members are welcome as well. So that's the way that we are really able to connect with them. And I think you heard certainly from the Title Health Team, and I know Tasita would say that in her work as well, that family members are really critical. So it really is a team based on the family side as well as the providers working. Sue, are you up now? I thought I heard her in the background. So referral of patients is absolutely welcome. We would love to see more of that. We certainly are working diligently with CRISP to be able to link more closely, and we certainly can provide classes statewide, virtually, and certainly in person when we finally get to that point as well. Are there other questions? And also, I'm wondering if any of our panelists have other information that they would like to share at this time. Are there screening criteria for providers to follow before referring patients? So interestingly enough, and I know Sue would be talking about this specifically if she were able to get her mic working. For the pre-diabetes program, DPP, there is some criteria. That criteria has really changed over time. It used to be a certain level of A1C. Now, weight is one of the other components that is looked at. And she may be able to give additional information in the chat or the Q&A, actually the Q&A. But in terms of the other programs for self-management, they are open to any and everyone over the age of 18. We do have some criteria in terms of mental cognition for older adults in particular. If they really have dementia, they're probably not a good candidate unless it's early in that stage. But other than that, really, individuals and their family members, these programs are absolutely open to. The organizer who was speaking about cell phones and working again in that area was actually Mr. Stanley Campbell, and he is with Eagle Force Health, and he will be presenting on September 22nd with more details about how U.S. providers can utilize those services and resources.
Okay, so I'm just going to, in the event of time, I'm just going to move forward and talk a little bit about the learning objectives for today for this presentation regarding the understanding and gaining access to the National Diabetes Prevention Program and the Diabetes Self-Management Education and Supports Program. So I heard somebody ask a question about screening. I want to talk a little bit about, I'm going to be talking about diabetes prevention and diabetes management today. The American Diabetes Association Standards of Medical Care in Diabetes include screening and testing recommendations for diabetes and prediabetes. Screening and testing is based on weight and age and other risk factors, And people age 45 and over who are also obese or overweight and have one or more of these listed risk factors should see their healthcare providers to get screened or tested for prediabetes or diabetes. Yep. So clinical guidelines for people at risk for developing type 2 diabetes include annual screening for people with prediabetes, referring to an intensive behavioral program such as the National Diabetes Prevention Program to help them lose weight and increase physical activity. One of the recommendations is to consider technology-assisted prevention interventions, and this is especially important as we've been hearing during the national emergency. Many diabetes prevention classes are now available through distance learning and online. In accordance with the National Standards for Diabetes, all people with diabetes should participate in diabetes self-management education to facilitate the knowledge, skills, and ability necessary for diabetes self-care. And diabetes self-management support is additionally recommended to assist with implementing and sustaining skills and behaviors needed for ongoing self-management. And there are 4 critical times to evaluate the need for DSMES, or diabetes self-management education and supports: at the diagnosis, annually, when complicating factors arise, and when transitions in care occur. I'm going to provide a little bit of detail about the National DPP and the DSMES program that are lifestyle interventions to help people prevent and or manage diabetes. And our office, the Center for Chronic Disease Prevention and Control, supports providers offering these programs. I'm going to start out with the National Diabetes Prevention Program. So I mentioned evidence base of the National DPP previously. That is, it can help people lower their risk of getting type 2 diabetes by 58%. Eligibility for the program includes the following. Participants must be 18 years of age. They must have body mass index equal to or greater than 25 or 23 if Asian. They must have a recent or within the past year a blood test indicating elevated blood glucose levels, for example, an A1C of 5.7 to 6.4 or a fasting glucose of 100 to 125 milligrams per deciliter. An alternative to the blood screening is a positive screening on a prediabetes test based on something similar to the CDC prediabetes screening test. I'll show you a sample of that in a moment. They may be clinically diagnosed with gestational diabetes, and they may not have a previous diagnosis of type 1 or type 2 diabetes and may not be pregnant. The National DPP is offered by trained lifestyle coaches who facilitate and support groups of people with similar goals and challenges, and it may be offered in person or virtually by programs that have obtained recognition from the CDC. It's structured as a 1-year program, which sounds long, but it's only 16 weekly core sessions, and then the remainder is every other week to monthly for the rest of the year. The curriculum content includes information about nutrition and physical activity and focuses on lifestyle change to attain the goals of 5 to 7% weight loss and 150 minutes of moderate physical activity per week. Referrals may be from a provider based on clinical eligibility or may be self-referral based on the prediabetes risk test. This map illustrates the headquarters of each lifestyle change program in Maryland within about a 10-mile radius. This number is growing all the time, and we have a ways to go to fill the gaps for in-person programs, but fortunately, we have virtual and distance learning providers who've begun to fill those gaps. In Maryland, there are currently 63 programs offering the National DPP via in-person, distance learning, or online. And providers are generally small community-based organizations, large hospital systems, local health departments, and other types that are sprinkled in between there. The National DPP is covered by Medicare, and in Maryland, the Medicaid Health Choice Programs covers it for people enrolled in MCOs. Click on it. This is an example of a prediabetes risk test. This is one that was jointly created by the American Diabetes Association and the CDC. And it's available there. And I also have a link to it on the resources page at the end. Now I'm going to move on to diabetes self-management education, talk about the key concepts. So there's considerable evidence that exists linking DSMES participation to positive changes in health behaviors and improved diabetes-related outcomes. And that includes improved hemoglobin A1C levels, improved control of blood pressure and cholesterol levels, higher rates of medication adherence, fewer or less severe diabetes-related complications, healthier lifestyle behaviors such as better nutrition, increased physical activity, and use of primary care and preventive services, enhanced self-efficacy or confidence to handle their disease, and decreased healthcare costs, including fewer hospital admissions and readmissions. Eligible participants can have type 1 or type 2 diabetes and can also be family members of people with diabetes. We heard earlier how instrumental family members are in reporting, and they're also instrumental in supporting folks with diabetes. DSMES is a 10-hour program that's offered by programs accredited or recognized by the American Diabetes Association or the American Diabetes Care and Education Specialists, which is formerly the AADE, if you've heard of that, American Association of Diabetes Educators. Classes are facilitated by diabetes educators, nurses, and pharmacists, and may be delivered as group or individual sessions depending on the need. Curriculum follows 10 national standards for DSMES and includes nutrition, physical activity, healthy coping, and problem solving, in addition to learning about treatment options, medication use, and preventing, detecting, and treating acute and chronic conditions. Like the national DPP, DSMES can be delivered in person, and the national emergency, during the national emergency, distance learning has been expanded from certain rural areas to all programs. So now DSMES providers during the pandemic are able to offer the program through distance learning where before they were restricted. And the goal of DSMES is for patients and participants to gain knowledge and skills needed to modify behavior and successfully self-manage the disease and its related conditions. DSMES requires a written referral from the healthcare provider. So this is a map that shows the DSMES program location, provider locations, as well as the geographic gaps that exist. And again, helped out by the distance learning availability. In Maryland, there are currently 38 programs offering DSMES at 52 locations. Delivery methods are usually in person, but during the pandemic, CMS has allowed all providers to offer the program during distance learning. And we really hope that this expanded delivery method will be maintained post-pandemic. Most providers are hospital-based or are wellness organizations, and there are a couple of DSMES providers that are pharmacies. DSMES is covered by Medicare. It's known as DSMT by Medicare and by other private payers. I'd also just like to mention that the Department of Health is working not only to support current providers, but to build a strong network of programs so that it is more widely accessible. So speaking of accessibility, there are several ways a person can find and or be referred to the National DPP and to DSMES. Our office maintains a customized website, behealthymaryland.org, where program providers may advertise their classes, and people may use the site to find classes and refer or to self-refer. So healthcare providers can refer patients through this online portal via secure email or secure fax. And program providers are also listed in the contact section to be contacted directly. Not every provider has a class going on at a time when somebody might look at behealthymaryland.org, but you can always find a program provider in your area that you can contact. The American Medical Association and the CDC created a toolkit for healthcare providers and patients called Prevent Diabetes Stat, and the toolkit will guide you through screening, testing, referring to a diabetes prevention program. And this tool includes a link to find nearby programs. So again, that speaks to the question about screening. Some Medicaid Health Choice MCOs are mining EHR or claims data using an algorithm for Medicaid for the National DPP and providing that information to healthcare providers in their panel or to program providers that they're contracting with with the expectation that they'll recruit or refer patients. And there's some evidence that a referral from a healthcare provider is effective in getting people to enroll and stick with the program. Many program providers partner with healthcare practices to receive referrals and provide feedback about the referral and patient progress. And healthcare providers may contact program providers if they wish to set up a referral path for diabetes prevention and/or management. And finally, healthcare providers might consider offering classes in their space, either through partnerships with program providers or becoming a provider themselves. And you'll find links to some of these resources that I mentioned at the end of this presentation. So this is a screenshot of our website, BeHealthyMaryland.com, where you can find the classes and contacts for the National DPP and the DSMES. All of these resources that are shown here will assist healthcare providers to help patients prevent type 2 diabetes or manage their diabetes. You and your care teams will be able to use this information to screen and refer patients to these two important community services. My contact information is also on the slide in case you need to get in touch with me about any of this information. I'll be happy to take questions. Thank you so much for your attention. Very happy that we worked out the technical problems.
Sue, thank you. It was so tremendously important for you to be able to present all of this important information. And I do have one question for you at the start, and that is from a Dr. Emily. He is asking, could you please share again the DPP eligibility criteria?
Sure. And I can, Sue, when you send out the slides, I can send out some information that's a little bit more specific or that's listed out, but it's participants must be 18 years of age. They must have a body mass index equal to or greater than 25, or if they're Asian American, 23. They must have a recent blood test indicating elevated levels of blood glucose. Oh, sorry about that. I forgot that I was supposed to be showing my video.
All right. That's all right.
Now, for the CDC class, they can have a blood test or the screening test, the screening risk test. However, if it's going to be covered by Medicare or Medicaid, they need to have that blood test. 100% folks need to have that blood test. They also may be clinically diagnosed as having gestational diabetes, and they may not have a previous diagnosis of diabetes, type 1 or type 2.
Okay. Thank you very much, Sue. Dr. Peters, I know that you're on. We would love if you had some additional information or thoughts that you wanted to share as we're getting toward the end of the session.
Sure. You know, it's part of our role in the Center for Population Health Initiatives to sort of help move the entire state toward better diabetes outcomes, you know, next year, 5 years from now, 10 years from now, into the next century. And one of the things that we really would like to emphasize is this, a theme that actually every presenter has hit on, is that there is a role to play for all of us, and each of us needs to rely on the other to find out what are these other folks doing? What do they really do in this organization? And oh my goodness, it's very helpful. Why don't I actually act on that information? So that's just one of the things that we want to emphasize, that there are people in the education system, in schools, who are looking at ways in which they can bring prevention messaging as well as environmental changes to the school environment that would then help prevent students who might be not having a healthy diet, or students who might be overweight or have obesity, and help them so that they don't continue on that trajectory toward diabetes. But for those folks who already are at risk for diabetes with known risk, or who have a diagnosis of diabetes, all of these really wonderful resources are so important. And we're hoping that all clinical practitioners would think about all of the other resources that might not be mentioned today, but that also might be really important for them to help manage their patients and help their patients do better self-management. The Health Information Exchange, CRISP, is a real key factor in all of this because it really helps to connect the data and the information that we need to use. CRISP has social determinants information, and CRISP has information about all sorts of things that are very useful for diabetes care. I'll stop there as I'm joined by my
It
6-year-old.
looks like you have an assistant who is there
I
ready to
do.
help you and to say hi.
I do.
And, you know, Tasita, I know you're on. I wondered if you had some closing thoughts for folks.
Yes, actually, just listening to everybody and their presentations and the resources today have really lets me know that I can tap into other things for the patients. So I'm really going to look at this slide over again and also take some resources and take it back to my team. It was really, really helpful.
Great.
So.
Wonderful, wonderful. I thank you all. I know we are very close to the end. I think we have managed to answer all of the questions. We thank all of you who have attended. I know it's late in the day, you've had a full day, but I do want to please encourage you to complete the brief survey and evaluation that you'll receive at the end of the webinar. And if you are planning to get CMEs, you will need to return that information to us so that we can get the CMEs to you. Again, thank you all. We are doing this again on September 22nd. That particular webinar is maximizing reimbursement. So that holds a lot of promise, a lot of opportunity for all of you. I want to thank our speakers who have just been fabulous. And so glad that we can get Sue Baith back up at the end. It's always a learning opportunity when we do this work, but we're grateful that we have this opportunity to be with you. So thank you all very much. Have a good night, and we will see you in a week.